I'm going to bring it back to you, Dan, and ask you if you can go over some of the very important supportive care and ancillary therapies that really are very important in chronic graft versus host disease.
Absolutely, yeah. Because that, I think that at the end of the day, what gives the patient the more immediate relief is adopting a lot of these ancillary and supportive care measures. And I'm glad you brought it up because they're frequently forgotten. They are not very well studied. I believe that they have the potential of sparing steroids, although that hasn't been looked at systematically, in part because it's very difficult to design a study that will, in a clean way, give us that sort of answer. But there are different ancillary and support care interventions that, to me, start with education, which needs to happen at the time of diagnosis. And this is crucial because it prevents the patient from having flares or worsening of their chronic graft-versus-host disease. And education has to do with things like using sun protection to avoid a reflare of graft-versus-host disease or worsening of graft-versus-host disease. When you continue down the different interventions, you have organ-specific interventions that have to do with management of dry eye or management of sores and lesions in the mouth, or dryness in the mouth, or management of mobility issues that have to do with scleroderma chronic GVHD, like in the case that we presented. And gynecological issues that have to do with vaginal dryness and also strictures, GI issues with GI strictures that can be dilated by gastroenterologists. There's a lot of different things that can be done. And unfortunately, they are frequently forgotten, as I said. And actually, these are the things that relieve that relieve the symptoms more immediately than systemic therapy. And sometimes, makes life worth living for the patients, because these are patients that usually live for years, and if they have severe chronic GVHD, they live those years miserably. So we need to remember that these are things that will help.
Usama, do you want to maybe touch a little bit on the long-term complications of steroid therapy and the things we need to do from a survivorship point of view for these patients?
Sure, Corey. So I am from a school where I think that leaving patients on glucocorticosteroids for a long time can be as toxic as the sequelae of graft-versus-host disease, whether that is acute or chronic. And as our cases illustrated, in the first case, you knew fairly early that the patient responded or will not respond. And you can move on into a second second line or other lines of therapy. Where in chronic graft-versus-host disease, most transplant centers do not have the expertise or the chronic graft-versus-host disease specific clinics or survivorship programs that can care for these patients. This is one. Two, I like to believe that 2 years after transplant, both us clinicians and patients lose the momentum that we started with transplanting our patients. Nothing acute is happening. So sometimes we can get adjusted and accept the new norm, which is not optimal. Okay, with that philosophical entrance, I think the real problem in the transplant community is you can scale the survivorship programs because you have the volume in Boston, where in most other centers where they do 50 allos a year, you cannot have that luxury of a survivorship sort of program and subspecialties. In many cases, having a colonoscopy and getting the call from the gastroenterologist, late at night telling you, Corey, this looks like acute GVHD or this looks like CMV makes all the difference. So again, having all these subspecialized programs and clinicians is a great thing to have. But I think we as a community, we need to work together to have some sort of consortia to treat this as a community. Again, I think I went and I derailed a little bit.
No problem. So before we wrap up, maybe just some final thoughts of what you think the future for GVHD holds. I'll go to you first, Dan.
I think, and I think you, Corey, will agree with this, I think we're moving into a phase of focusing more on preventive therapies and proactive intervention versus wait until the manifestation of any chronic GVHD or any GVHD for that matter is meaningful. And I think I think that new way of doing clinical research, plus the existence of agents that are a lot more active than what we've seen in the last 20 or 30 years, are a good combination. I am very hopeful and optimistic that in the next 5 or 10 years, we're going to improve outcomes even further, and not just because our supportive care is better, but because our treatments of the disease are going to be better.
Usama, your final thoughts?
Final thoughts. I'll echo Dan's point that actually rates and severity of acute graft versus host disease are decreasing now compared to even 10 years ago. Better HLA matching, better prophylaxis platforms, and other supportive care issues. So number one, so this is good news. Number two, I think with both the approval of ruxolitinib in steroid-refractory acute GVHD and ibrutinib for chronic GVHD, now the bar is higher. So with response rates, in the acute setting between 50% and 70% in the chronic setting for ibrutinib, the bar is higher. So when we design our clinical trials now, we have better agents to compare to.
Great. I couldn't agree more. I think being in this field now for nearly 20 years, it's quite a difference. We have this embarrassment of riches of agents and pathways and strategies to test. I think we are only going to get better, and transplant outcomes are only going to improve as a result of this. So with that, I'm going to thank both of you for your thoughtful case presentations, your discussion, your candor. To our viewing audience, thank you for joining us for this Targeted Oncology Virtual Tumor Board. We hope today's discussion was a valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic. And with that, we'll thank you very much.